the Dementia Researcher podcast, talking careers, research, conference highlights, and so much more.
Hello everyone and welcome to the Dementia Researcher podcast. We're here in Amsterdam at the International Lewy Body Dementia Conference, and it's my honor and pleasure to sit with these brilliant scientists who have attended the conference. And I'm super happy that the conference is here in my hometown in Amsterdam. I am Sterre de Boer. I'm a postdoctoral researcher at the Alzheimer Center Amsterdam. My research focus is actually on fronto-temporal dementia, but for my clinical work I also see patients with Lewy body dementia and other types of dementia. So this conference is also very relevant for me, and that's why I was super happy that it was very nearby my house and that I could attend this year. Enough about me. There were a lot of highlights to discuss, and I would like to introduce our speakers. First, I would like to start with Salomón Salazar. Maybe you can introduce yourself and what your work is and what your interest is.
Thank you, Esther. So I'm Salomón. I'm from Colombia, med student at Xavierian University in Bogotá. So I'm also an ISTAART ambassador. And my main interest and research is around the DLB consortium in Colombia that works in collaboration with King's College London and the Stavanger University Hospital. And I also like some things around geriatric assessment, frailty markers, and conventional biomarkers in dementia. And that's what I do in clinical and research side.
Super interesting, thank you. Next to you is Lauren Walker.
Yeah, so hi, I'm Lauren Walker. I'm an Alzheimer's Research UK Fellow based in Newcastle in the UK. So my focus is mainly neuropathology, so I'm interested in dementia with Lewy bodies, and to be at this conference, and more specifically kind of concomitant pathologies, in particular how AD-related pathology can influence the clinical and the neuropathological phenotype of patients with Lewy body dementia.
Thank you so much. And then next to you we have Felipe Botero Rodriguez.
Hi, I'm Felipe Botero. I'm from Colombia too. I'm a psychiatrist, and my focus is on neuropsychiatric symptoms related with dementias. I just moved to Norway at Amsterdam to Stavanger University Hospital to work at Professor Dr Orland labs.
Right. Thank you, and great for everyone here to be part of the podcast. This is actually the second part of a two-part special on a podcast on the conference. So if you already so if it's the first part you're listening, please also check out the first part and then rush back to this podcast because we also have some interesting highlights to discuss. And that actually brings me back to you. I think you've all been presenters at this conference, being either a talk on the podium or a poster. So maybe we can start with you. What was your poster about? What was your,
Yes, so I presented today my poster. It is a review that we built around the Colombian DLB consortium about DLB research in Latin America. In our consortium, we have different steps, and the first step is to know what are the gaps and opportunities for DLB research in our continent. And as a brief resume, Brazil has an enormous lead in publications compared to the other countries, so there is an underrepresentation within the underrepresented. There is a very limited number of clinical trials, and also most research is cross-sectional, so really we are not assessing causality in Latin America related to LBD research. Also there was almost none neuroimaging or biomarkers research, so that's also important. Most research was clinical focused, which makes sense because it's the cheapest one to make and also the one that is more accessible based on memory clinics. So yeah, we have a lot of work to do, and the second part of the consortium will be told by Felipe. Okay. So wait for that.
Okay, well maybe then it's a nice way to go to your poster. That's
great. Yeah. My poster was about the prevalence of DLB, prevalence and associated related factors. We found anything I think very important and very highlighted. There is a very low prevalence, 0.6%. So that gives us a space for a lot of hypotheses. For example, it can be misdiagnosed, underdiagnosed, I think a bit, but also, and regarding your research about FTD, there are some papers about the genetics ancestry in Colombia that tell or that explain a higher prevalence of FTD because of that. It also can be a related factor to that low prevalence, but I really don't think that the reality or the real prevalence be as low as we see. So there is a lot of things to improve and to study. This is the second step, and in Called DLB, we are working in the third one to make a prospective study based on the EDLB protocol.
Right. Oh, very interesting.
Just to add up on that, the prevalence that Felipe said, it was in our own memory clinic. So it is a prevalence of a tertiary center that you will expect to be higher, but it wasn't. And we actually have the largest one of the largest memory clinics from Latin America. Our database has more than 5,000 patients, but very few DLB patients.
Yeah.
So we really need to dig on that and see how percentage it is because of underdiagnosis, what percentage it is because of misdiagnosis, and what percentage it is of something very different that we have not found about DLB in Latin America.
Yeah.
So the DLB, obviously the diagnosis that you do, is that neuropathological confirmed, or is that purely based on the clinical symptoms?
Purely based on
Purely
clinical
clinical.
symptoms, yes. We use, of course, the McKidd criteria, but we cannot confirm the diagnosis based on neuropathological, or maybe use ID biomarkers. We neither can to see if there is copathology or maybe a misdiagnosis with AD. We can't.
Yeah.
That's a problem, and maybe we can go further in the podcast about dementia clinical practice in Latin America.
Yeah,
we are good clinicians because we have to, because we don't have other tools. So yeah, it's purely clinical.
Yeah. I think it's super important that we bring that awareness as well to an international conference like this. You know, I think there were 32 countries attending this conference, and DLB goes beyond borders, of course. So I think it's very important that you bring that awareness to this international conference. But it also, raises questions for me, like how are you going to investigate where the cases with Lewy body dementia are in maybe more remote areas, maybe not in an academic hospital. Do you have any already protocol or plan or methods how you're gonna
So we have a few ideas. We want to collaborate with other centers in Colombia.
Yeah.
One of the centers is the Grupo Neurociencias de Antioquia in Medellín, which is the group that follows the largest kindred of patients with autosomical dominant AD, which is the well-known Colombian families with AD. So they have a lot of experience of dealing with patients with the disease and how to find patients in small towns or in zones that are more rural. And we also will collaborate with a group in Cali, which is called Fundación Valle. Cali is another city in Colombia that also has experience in tracking patients, but more in the movement disorders part. They have a very strong research in PD. They belong to large PD and other research consortiums. So we are like working together.
Yeah.
And also I want to mention that our collaboration with Professor Arslan, like Felipe said, is because we want to have blood samples and CSF samples from the patient, but to send them to King's College London or to Norway to have there the analysis of biomarkers, because that's the way of starting.
Yeah.
It's cheaper than bringing the technology. So that's the idea. Yeah.
Well, it's very nice that the collaboration is already ongoing, and that there's these opportunities to share expertise and equipment all over the world to do this research. And how does it then, if you go to this conference, because like you said, we use the McKeith criteria, but we can't use all the maybe biomarker tools that other sites are using, then how is it to attend to a conference that you see that's starting to become such an important part also of clinical practice that maybe you can't already bring back to your clinic? I'm always very curious to ask, like how is that?
It's like a little kid to see a candy but can't have it.
I
will compare to that. And I have talked a lot to Felipe about this. Because personally I love biomarkers. I really read the papers about biomarkers, but I can't use them. But I think it's great that we see the conference and learn how to biologically define disease. Because once they arrive, we are going to be ready to apply it. But I also think that we need to be cautious because biomarkers won't behave the same way in Latin America that they do in Europe for a lot of reasons. So maybe we have different cutoff points. Maybe we have other factors that can change how biomarkers behave. But also I think that, for example, in Europe or North America, biomarkers arrive in a certain order. So you have CSF, you had PET, now you have blood. We will have blood before all of that. So that will change how you apply biomarkers. If you read a guideline about AD biomarkers, that you use the blood biomarkers and then confirm diagnosis with PET, that doesn't apply to us because how do we confirm if we don't have PET but only the blood biomarker? So that will be a crucial topic I think, in the next years for dementia research.
I think that's super interesting you're bringing this up. So I think that, like you said, the order is kind of reversed actually.
Yes.
And so I think it would be super interesting to see the effect as well in the clinic, but also the research. And maybe that also brings then a question to your field, Lauren. Do you actually see the difference in, the pathological confirmation or mismatches maybe from what in the clinic and what you see under the microscope? Did you see that change over the years with all these biomarkers coming available?
We do. Neuropathologically, when we get the tissue into the brain bank, obviously we go through a load of neuropathological tests and a load of neuropathological experiments to confirm or understand what the mismatch in diagnosis was. And this is kind of some of the things that I was talking about on Wednesday. So I did talk on Wednesday, looking at how AD-related pathology can affect the neuropathological phenotype, and how we may be able to relate that back to the clinical symptoms that we see in the patients during life. Because a lot of the time, patients with DLB get misdiagnosed as Alzheimer's disease.
Yes.
And up to 30% of patients with DLB will have enough Alzheimer's-related pathology to also categorize as a full diagnosis of Alzheimer's disease. And when we look at these cases under the microscope, these particular cases have a different distribution pattern of pathology. So DLB cases that have very high tau tangle loads look very different to the cases that have very low tau tangle loads. And more specifically, it's the amygdala that seems to have a lot more a lot more alpha-synuclein pathology. It has a lot more tau pathology, more so that it's affected than any other brain region that we've studied. And we use a tissue microarray system, so we can look at 15 different brain regions on one slide, so we can get a whole load of information. And what we found in our study is, as I said, the amygdala is very highly affected. It seems like it's a bit of a hotspot for pathology for both tau and A-beta. They co-localize within the same cells. And in addition to co-localizing the same cells, they co-localize in different subcellular compartments. So we think there could be a potential interaction between these two proteins that could be driving the diseases forward. We just don't really fully understand these relationships yet. And it's difficult to do that with post-mortem tissue, obviously. But there's a lot of animal research and in vivo models to show that these protein interactions could potentially drive the disease forward, both neuropathologically and clinically as well. So,
yeah, it's very interesting. Yeah, so I think there's more, like you said, when this information becomes available, of course, we'll also get more information about how to translate into what we actually see in the brain happening, and vice versa as well. Because I also know you also correlate all the pathology back to the clinical symptoms. Yeah,
we do. Yeah.
Yeah, and was there anything particularly striking what you saw in this more amygdala hotspot cases? Was it even possible to disentangle all that information and symptoms?
Don't have that information yet, so that's something that I'm now going back to. Excuse me. So we take all of we have research nurses that do clinical tests annually on all of these patients, and it's just starting to dig back through that data to see if we can correlate anything with these cases that particularly have a lot of pathology within the amygdala. And I think this is something that we're going to talk about more in the Brain First, Body First hypothesis, which is obviously one of the talks that was given at this conference.
Yeah, yeah. And so I'm already curious and interested in what you're going to find in your ongoing research on that topic as well, especially because I think we have also clinicians here on the couch, so we're always curious to see how that relates back to what we see as a phenotype and how that can help also with our diagnostics. And then, so we've talked a little bit about what we've presented and also about what you've presented. Were there specific highlights for during the conference that you would like to, talk a bit more about?
Well, I would like to highlight the debate between body first, mind first, because of course it is very important, but in the clinical practice it could be almost the same in the clinical practice. What I mean is that the patients have a lot of clinical manifestations, right? And here open the doors to neuropsychiatric symptoms. Neuropsychiatric symptoms is very important because it's related with burden of disease, burden of caregiver, and it affects quality of life and wellness. So we can, in this moment that we don't have yet any treatment, any cure to these diseases, I think it's very important the quality of life, to mitigate the symptoms, and we can see it in neuropsychiatric symptoms in one hand. In other hand, it I think broader the what we can see at the clinics. For example, it's not only movement disorders that is very important, but it's another option. The affect, psychosis, the thought, anyway. So I think it's very important this debate, precisely for that, for open our eyes, open our minds, and be aware of other manifestations.
Yeah. So you're referring to the plenary, right, from Per Borkhammer of Body or Mind First, I think you were saying? Yeah. And what maybe this, I'm just going to ask you, but if you don't have an answer, that's also okay. But what do you think is first, then, the body or the mind?
Well, my response depends on the site, on my work location.
Okay.
Because if we talk here, because of my biomarkers, I could say bodies first. But in Colombia, in Latin America, I would say mind first. Clinical manifestations first. And it also opens the door to non-conventional or atypical biomarkers. Why can't we say that neuropsychiatric symptoms, for example, mild behavioral impairment checklist, why this can't be a biomarker, a non-conventional biomarker? Of course, it's very different, and the sensibility, specificity would be very different than CSF biomarkers.
Yeah.
But we have to work with the thing that we have.
Yeah.
So
Yeah.
it's a first approach.
Yeah. And maybe I can ask, I think it would be interesting to also ask you the same question. Like, what do you think, as more as from the pathology side, what do you think is first?
I will say I really enjoyed Per Borkhammer's talk earlier today, and the amount of data that he presented that was clinical, that was neuroimaging, and the neuropathology data sets that he looked at, plus the animal models as well, I really love his work. I really appreciate reading his papers. I think both, as the short answer, I think both will play a role. In terms of neuropathology, we have cases in our brain bank that have amygdala-only Lewy bodies that don't have any other involvement.
Yeah.
So, and we've just been, these are normally incidental Lewy body cases. Whether they will go on to then to develop a clinical syndrome, who knows? But we have cases that are amygdala predominant, amygdala only, and olfactory bulb only. So there's definitely a strong case for brain first and body first hypothesis. I think what surprises me the most is, because when I started thinking about this, my opinions would be, well, DLB is obviously going to be brain first all of the time, because obviously the 1 year rule, they have the cognitive symptoms.
Yeah.
But in his data, he showed that 66% of DLB cases were body first. So it's still something that I'm trying to kind of wrap my head around. And what he's saying it makes a lot of sense, that a lot of these DLB cases will have an abnormal DAT scan, but will have a normal MIBG, and some will have a normal MIBG and haven't a completely normal DAT scan. So I can see how both mechanisms will play a role. And as I say, the post-mortem data sets that he's been using, the amount of cases that he's got, which I think is really important to look at. I think what we struggle in a lot of these data sets is looking at diversity, which is a problem that I have with our cohorts as well. 99.9% of the people that come into our brain bank are white Caucasian. So, and I've got a feeling a lot of the bigger data sets that he uses as well probably don't have that much diversity. So it'll be interesting to see how that actually translates into kind of larger data sets and more diverse data sets. What I also find interesting is the animal models as well. When you inoculate in different injection sites, they show this different distribution patterns. So I definitely think there's something going on there, and something I'm particularly interested in is how the contribution of different pathologies. Obviously, the brain has Alzheimer's pathology, it has TDP-43, there's vascular lesions, probably the things that we don't know about yet, and how that could play a role. I think it's a lot more complicated, and adds to the heterogeneity that we see in Lewy body diseases.
And I'm talking about TDP-43. You
Yeah,
can say a lot about that.
Yeah.
For example, I don't know if you remember the talk about the session about pathologic assessment. There was a talk that says about patients with early onset DLB versus late onset DLB. When they, at one of the almost last slide, was comparing the pathology between groups. And I was expected to find a lot of more TDP-43 pathology in the younger patients. Why not? Because of a differential diagnosis with FTD or they have a different burden, but they had not. I didn't, and the older patient didn't even have more AD pathology. So it's rare. The co-pathology, it's a really interesting topic, and yes, and TDP-43 is really underrepresented. People need to talk more about it, other than late, also in how it behaves with the other pathologies.
Yeah,
It's important.
yeah. And I think you were already saying about the order of biomarkers coming available. I think maybe I'm not a pathologist in any way, so please correct me if I'm wrong, but I also understand that when we, found out more of the pathology types and more of different staining, and, it's quite also, you have to go back to the old cases and, maybe you already, back in the day, you would stop if you find AD pathology. It's like, oh, it's AD. And then you wouldn't do all the other stainings. But now I know, people do all the stainings just to see what the co-pathology is their co-pathology. So I think when we get more knowledge of what's there throughout all these decades of research, we also, have to do more work to see what is actually the co-pathology and not just the first pathology we found back in the day. So,
we did that recently with TDP-43. So in the last, I think we published a paper in 2021, just after latency had been kind of defined.
Yeah.
And we went back through our neuropathological cohort that had an AD diagnosis with controls and with DLB, just to kind of get the prevalence of what TDP-43 looked like in these cases, because the stainings hadn't been done because we weren't aware of it.
So we're probably going to get more of that in the next,
Yes, and I think dementia can be as complicated as you want it to be. Like for me, dementia has always been an umbrella term. So you have the neurocognitive disorders, MCI, dementia, and then you can have Lewy body dementia, but you can have Lewy body dementia with AD, Lewy body dementia with vascular, and so go on. So in the era of personalized medicine, we will have to have a debate of how much personalized we will want to be. Because in one point, being more personalized won't change patients' outcome, and that will be the important part, because it will be more expensive to be more personalized, but at the end, what's the goal of it?
Yeah, enough challenges ahead. Salomón, I have to, of course, also ask you the question, what your body and mind, what would you answer? I know it's a very difficult question.
I will dodge the curveball and say it depends.
Okay,
Patients can have both, I think. Like, as you said, 66% of the patients with DLB can have the other way around. So it depends up to the patients. And it's a spectrum. Like, as you can have PDD and DLB, you can have DLB body first, DLB mind first. And it is an important topic because it changed clinical trajectory of patients, and it changed how they need to make some priorities regarding their clinical care and caregiver, all of that. So both.
And I think also really nice what Lauren said as well, right? It's like, it's not like the mind is separate from the body at all. It's all intertwined, like it's all affecting each other, and the body is the mind and vice versa. And I think that's also really nice that, how we also have this interdisciplinary couch today. So we have some people, I think you're a psychiatrist, if I'm correct. Yeah. You have someone working in pathology, you work in neurology and biomarkers, I work in neurology. So like we're already showing that it's not just one discipline that's going to fix all these challenges. We really have to work together. But I think it's nice that this was such a provocative plenary that was there during the conference. And I also think there was a highlight mentioned of another debate that was today. Maybe Lauren, you can share a bit of the debate that was happening. I think this was I will say the statement. The House believes that DLB and PDD are still useful concepts. How was it? How was the debate?
It's always an interest, and it's one of the highlights of this conference that we always have a debate, and it's always very well attended, and it's always good humoured, and so it's always on an important topic. Things like the 1-year rule, and this year DLB and PDD still useful terminologies. I voted yes. I do think it's useful looking in terms of different disease types. But what I will say is that things like treating pathologies, individual pathologies will help all of these patients regardless of what their label is.
Yeah. And Felipe, you also mentioned it that you enjoyed the debate. Do you want to share what your point of view was on this?
Well, I really like the pragmatic point of view that it could be the same. I mean, maybe at microscope, and it's very important, it could be different. But when assessing the patient, it could be the same. And even the treatments are very similar, and the responses are very similar too. So it could be a last name if it's only Parkinson or if dementia with Lewy body. So maybe it could be the same, and we can go forward to manage the same entity, or to manage it like the same entity.
Do you think at where we are right now that would also benefit the patients, or do you think it's more benefiting research if we come to that consensus?
I think it's more beneficial for research. For patients, maybe it is the same.
Yeah.
Because it could be another variable to confuse them, to the patients and families. So for clinical, I think it's almost the same.
Yeah, and what is your point of view on that?
I had a difficult point of view because at the beginning of the debate, sorry, I voted that it was different. At the end, I didn't vote. I agree with what they say that in the prodromal stage it is very similar. At the end, it's very similar. I completely agree, but patients don't really care about both ends. They care about the middle part, which that's where it's different. That's where patients have different clinical trajectories, and that's where we need to really take good care of them. So I understand the pragmatic approach. It may be easier, but during the clinical trajectories, extreme the prodromal at the end age, that's where we're going to find the difference. So I think for the moment, I will use the DLB PDD approach. Maybe if we have widely available alpha-synuclein SA, that would change maybe the scope, because some people at the debate said that we are treating patients not with DLB, not with PDD, but with alpha-synucleinopathy. But I don't agree totally with that statement. But maybe in the future, with widely availability of biomarkers, I can change my answer. I have the right to.
No, I think it's also really nice to see that, throughout the debate, you didn't change your mind, but you did get maybe a different, viewpoints, and you will take that into account, of course.
It's great to change what you think. Like if everyone is thinking the same, someone is not thinking.
No. I'll ask all of you the same question in the next conference. See how we go.
Perfect.
And I also remember before we were starting the podcast, you also said you also really like the plenary or debate as well on how we can use the biological framework that's currently really starting to emerge within the Alzheimer field. How that can, what can we learn from that in the DLB field? I was wondering, so you already mentioned that I really like biomarkers. How was that for you to be part of that talk, and how did you find it useful, maybe also for your research already now?
It was an excellent research session. All yesterday afternoon, like from the plenaries to the debate, they were great. I also really liked that they had Dr. Sheltens to have the AD perspective, because I think we can learn a lot from AD. We have that advantage. The AD folks didn't have an example. We have an example. And I think the bigger question is not whether to see if we use the synergy approach or other approach, is whether we want to say that DLB is a solely biological entity, or we want to have a biological and clinical approach. So bringing that to Alzheimer's disease is Alzheimer's Association criteria versus the International Working Group criteria. I think that's the main thing that we need to discuss. And it was discussed. I remember Professor Lang talking about, and what for me is one of the biggest arguments, is that not all patients with neuropathology will develop symptoms. And I think you know that as a pathologist. And if a patient won't develop symptoms, why you want him to treat him or to do a disease-modifying therapy that maybe won't do good for him? For me, that's key. And that perspective paper that Professor Lang highlighted about disentangling clinical trajectories from Professor Villan in France, because French people are the most about the clinical, biological clinical framework. It's really, really great to see how they show all the different trajectories that a patient can have. And we also need to agree on how are we going to call those patients with a positive biomarkers but without clinical symptoms. because the Alzheimer's Association criteria says that they are already with the disease, Alzheimer's disease. They are not ill, but they have the disease. And the international working group says that they are at risk of AD and that have a lot of implications, social implications, health implications. It's not the same to say a patient, you are at risk of AD, or saying you have Alzheimer's disease. If someone says that to me at I don't know, 65 years old, what am I going to do? I will be scared. Maybe I will develop symptoms. But maybe yes. So I also understand the other side of if I have a disease-modifying therapy and I can give it to the patient very early, of course I would like to know. But I think that in the next DLB conference, we need to have that discussion about, is it going to be at risk of LBD with alpha-synuclein, or is it going to be with alpha-synucleinopathy? Because that's the other thing. You have the Alzheimer's Association criteria, you are talking about Alzheimer's disease, and you are saying you are at risk of Alzheimer's disease. Here you are going to say you are at risk of multiple system atrophy, you are at risk of Lewy body dementia, you are at risk of Parkinson's disease, or maybe that's where you need to make them the same and say only Lewy body disease. We have a lot of debate to do. It was an excellent session.
No, I really appreciated the fact that they had, it was Tanya Smooney from Chicago, Anthony Lang from Toronto, so the two lead authors of those two papers, and then obviously they have Philip Shelton's on the ATN perspective, and then David Byrne from a movement disorders perspective. So it was a very nice conversation, and I think what I really appreciated, they went through the pros and the cons of each of the staging criteria, and I think what I appreciated the most is the fact that both authors said this is version 1. So I remember reading the papers thinking, this isn't going to work for DLB right now. So there's a lot of things that I think that they're obviously aware that we still need to progress, but you've got to start from somewhere. And we do need to take lessons from movement disorders and the Alzheimer's field. And you're right, people with incidental Lewy body diseases, what does that staging system mean for them? They might not ever go on to develop a clinical syndrome. And by the same token, 50% of Alzheimer's patients will have synuclein in the amygdala. What does it mean for them? If they've been labelled with this, you've got Lewy body disease as well. It might never manifest clinically. It might never affect their Alzheimer's disease. So, I really appreciated the fact that it was like, this is version 1. Version 2 will incorporate core pathologies. It'll incorporate quantitative seed amplification assays.
And just to say one small thing, one thing that is important is the effect of treatments. So, for example, we always have the comparison with the cancer field and the cardiovascular field, saying that, for example, if a patient has ovarian cancer and you take a biomarker of, say, CA125, you can take out the ovary or you can give, but in dementia, you can't take out the brain. Or if you talk about cardiovascular disease, you take a blood test and the low density lipoprotein is high, you can give the patient a statin, but here, yes, you can give them lecanemab, and we are making huge progress, but it's not the same thing to give a patient atorvastatin versus an infusion therapy with all that is implied. So I think that as disease-modifying therapies will advance, also the biological definition of the disease will advance at the same time. And in DLB, we have an advantage that in Alzheimer's, the definition has changed around the availability of disease-modifying therapies. In DLB, we are not at that point yet. So we have the chance to do a definition of the disease without the pressure of those treatments. So that also will be very, very important.
And Felipe, we always compare what the Alzheimer field to DLB. I've noticed this, of course, also in the FTD field. Like you said, I think it's very nice how you say we have an example, so we have to use it. But what can actually the Alzheimer field learn from DLB research, you think?
Well, I think that it's very important that the DLB field maybe has been a little underestimated. So in work or being that second layer works to go ahead without pressure or with less pressure in one hand, and looking another kind of symptoms. You know? At the beginning, Alzheimer was only forget things, memory. We were talking about this the cognitive homogeneity, hegemonia. But in Lewy, it's very different. Indeed, I think that memory is not the main concern in DLB. or LBD, any of both. So what can the AD file learn about the LB file? I think that look not only the cognitive status, that is of course very important, but all the domains.
Yeah, I think that's what I also really appreciate from the conference. I'm coming from a different, focus maybe within dementia, but I really enjoyed that there were so much ways of, phenotyping all the patients and a very, like high level, well thought test, different viewpoint, going from the phenotype all the way to pathology and back, using not just biomarkers to phenotype, but also really good clinical assessments. And that's what I really took home as well for myself at this conference. So really nice that you also point this out. And I think it's so important as well, like all the clinicians we were mentioning it a few times, but never to forget that, what you actually see on the outside. And then we're so lucky to have pathologists working on how we can then actually translate that and correlate that what's happening in the brain.
Yep, to add to that actually, I think something that we can learn from the field of DLB that we can apply to other neurodegenerative diseases is because DLB is so heterogeneous, we can't just look for the protein aggregates. We've known for a long time that alpha-synuclein in the brain doesn't correlate well with clinical symptoms. So we need to look further around that. An example of that at this conference is one of the posters that I looked at by David Costa's group in Dundee. And he's looking at DNA damage and how that can influence clinical symptoms and disease progression in dementia with Lewy bodies. So what they did is they've looked at post-mortem tissue and found that alpha-synuclein is present in the nucleus. And they found that this alpha-synuclein is also seed competent, so it gives a possible amplification assay result. And they're starting to take this further, so to look at different DNA markers and how that affects the different neurodegenerative pathologies in the brain. They've also looked at different proteomic analysis as well. And it's DNA damage enzymes that are upregulated in this brain tissue. So it's kind of taken a more holistic approach that it's not necessarily just about the proteins that we see, but it's other, specifically other mechanisms that could be influencing the disease progression as well. And I think that could, because we've had to do that in DLB, I think this is something else we can take to different fields as well.
Yeah, I feel like you're really, almost embracing the heterogeneity. It's not like, something we're trying to tackle down all the time. It's really trying to see, okay, how can we then approach this disease in the most holistic way, like you're saying. Yeah.
And for example, this can lead on to repurposing therapies that we've never usually considered. If we're trying to target alpha-synuclein all of the time, we're missing chances to repurpose different existing therapies that could be promising.
Yes.
Yeah. Very nice.
And that brings out a point that maybe at the conference we didn't have the chance to address, and that is cognitive reserve and resilience to clinical symptoms, because that complicates the landscape a lot if you include potentially modified risk factors and why some patients develop symptoms and why others not. That brings another variable to the heterogeneity, which is very important, but it's the hardest to assess, because why is this patient with alpha-synuclein will develop symptoms and this one will not?
Yeah. Were there any other highlights that we didn't discuss that you feel like we should really share with the audience?
Well, I, not surprisingly, really loved the pathology session.
Yeah.
So there was a few talks in that, but in particular it was Lisa Mikkelnikas from Helsinki in Finland, and she's a neuropathologist and looks at. In Finland, they've got some massive post-mortem cohorts, which are fabulous. It's hundreds of cases. And she is specifically looking at the underdiagnosis of Lewy body disease, which we've known for a long time. It's very underdiagnosed unless it's pathologically confirmed, and it's misdiagnosed as Alzheimer's disease a lot of the time. And what she found is I think she had 500, it's the Vanti-85 study, and it was over 500 cases that she was looking at, and she'd stained the post-mortem tissue for alpha-synuclein. It was brainstem regions and it was the hippocampus. And it was from ages 19 up to, I think it was 94, and found the youngest person to have an alpha-synuclein positive immunohistochemistry in the brainstem was aged 54. So a long time before we start to see the clinical symptoms. So I think she'd estimated, I think people over the age of 50, there's Lewy body pathology in about 9% of that population. So it's a population-based cohort. So obviously not hospital-based, so it's very representative of the environment. And I think it's important that, and obviously biomarkers will help us detect these when we have a good biomarker or when we have a good blood biomarker or a good neuroimaging scan, which unfortunately we don't have any of these. And this is where we struggle a lot of the time at neuropathology because we get very end-stage tissue. So a lot has already gone on in the brain, but I think that study really highlighted that we need biomarkers and we need them pretty quickly for at least alpha-synuclein so we can start and track this disease in midlife and get a better representation and better diagnostics for patients.
Yeah, I completely agree with you, and I remember really well the session. It really made me to ask if that pathology is present that many years ago, how many years ago a biomarker will be positive? Because in AD we already have evidence related to that. I remember that New England Journal of Medicine paper that shows how clinical trajectories of patients decades before the symptoms can have a positive AD biomarker. And that brings us to the same question that we did before: is why will you do that biomarker in an asymptomatic patients? Here is the same. It's the same thing. You have pathology in patients that are that young. What will you do? Why will you do a biomarker? I wish I could do it to give a perfect treatment and that the patient didn't have the disease, but in this moment it is not possible. As people yesterday say, we need more data. That's the conclusion of the conference. We need more data.
Well, I think that was also, that's always very clear after every conference, right? We need more research, we need more data. But I also felt like this was the first time for me attending this conference, but I really felt this really, motivated group, very enthusiastic. People are very willing to collaborate. I think it's very, like you said, maybe the field is underestimated, but I felt like when I was sitting in the audience, like this, they're the one to watch, I think. I think stuff is going really quickly, and it was nice to immediately compare also the conference from 2 years ago, when they showed, after the conference we did this, we found this. So I think it's moving very quickly, and hopefully, all the things we were wishing for, and hoping that I think in 2 years they will actually already be there. But I actually think, like you say, I think it's underestimated, but it's that we shouldn't.
I completely agree with you. It's also my first time in this conference, and you can see like the community is really closed, really open to having a conversation about something. And I also want to highlight the work that they are doing with early career researchers like us. That's incredible. Like they really want to be good mentors. They really want more people into the LB fields. Multiple times they say like we need early career researchers. We need people to take over our position when we are retired. So that's also great that they are thinking about early career researchers and including them in the conference.
Yeah, the next generation. Yeah,
that's
super important. Yeah,
I agree.
I think we already touched on the pathological session as well. Was there any other session or plenary or talk that you thought I have to mention this before we end our podcast?
Maybe we can talk about the Ian McKeith Prize. That was great. A good recognition.
Maybe you can explain it to the audience.
So the first thing that happened at the conference after it was like started, they handed to Dr. Ian McKeith, as the one that wrote the criteria for DLB diagnosis, a prize named after him. So the Ian McKeith criteria was given to Ian McKeith, and the idea is to highlight the work of seniors researchers in the field, and I think it is important. And it has a good name for the prize. We will see who gets it next year.
Well, maybe one of you on the couch, who knows?
In a few years. But that was important. And also his talk after the prize was great to see all the work doing all these 30 years, and also the prodromal diagnostic criteria is really, really important. Like they are up to date, and they have the clinical biological perspective. They don't have yet the only biological definition of the disease. That's great. You gave a really nice, I think, overview, and also almost a history lesson, but in a way to really inspire and motivate, I think, everyone who was sitting in the room, and to, like you said, like if you know where you came from, then you also know where you're going and where you were going ahead. So I really enjoyed that talk as well. It was very good. And I think, very lovely prize, of course, and I'm very keen to see who will be the next recipient of it.
I just have one more highlight that I'm interested in. So in terms of kind of blood biomarkers, I'm interested obviously in AD core pathologies and DLB, and how we're starting to use p-tau 181 and 231 to identify core pathologies in Lewy body disease, because obviously once we have a good idea of core pathology, if and when disease-modifying therapies come through, we can give it to the patients that need it. And there's been a few posters in, it was on day one, and obviously it was a biomarker session. And I think something that we're really struggling with right now is that DLB patients, that it was a post by Leonardo Stroulianis from Cambridge, and he specifically looked at patients that had a diagnosis of DLB and patients that had a diagnosis of AD, and he looked at p-tau, I think it was 217 and 231. And at the minute, there's very little difference to separate the two conditions, which I think is something that we're going to need to work on. So I don't think it's going to be one biomarker that will differentiate between AD and DLB, because they all have a certain amount of pathology. So there was no clear definition. So I think what I'm taking from that is that it's going to be a panel of biomarkers that will be able to hopefully in the future give us a more kind of definitive diagnosis in patients that have DLB, but with also additional Alzheimer's related pathology.
And I want to do a comment on that, because eventually maybe people will start thinking of what if we try disease-modifying therapies from Alzheimer's disease in patients with DLB. That's where biomarkers will play a very important role, seeing if patients will have the same clinical progression or it will change. But third, there will be also an important factor, that is vascular pathology. That is also forgotten in DLB, but it's also very, very important, because if we are thinking of giving patients with DLB disease-modifying therapies with AD based on co-pathology, we also need to assess if this patient had a big burden of vascular pathology, because that will forbid us to use that treatment based on the risk of ARIA. So I think that if we see AD co-pathology in DLB, we also think to see vascular co-pathology in DLB.
And not eventually. Indeed, that is happening now.
Yes.
You see the pipeline of treatment of clinical trials, and most of them are related or has been tried for Alzheimer.
Yeah, I agree. And the group from Karolinska Institute from Dr. Ferreira with Anna Renier, she's a PhD student, has a lot of work related to vascular pathology in DLB, and they have evidence that supports the fact that vascular pathology is common in DLB, and you can see it in the MRI, so you don't need to go to the pathology. In vivo, you can see it, so it's really important to take that into account. Yeah.
And I think what you're saying, we probably need a panel, and I also think that during the biomarker session, also Charlotte Teunissen was also mentioning, right, that she's trying different panels on different types of assays to really see what is the best combination, not just to differentiate DLB from controls, but also from AD, and what does co-pathology do? And I think once we are there, then the next step will be, what does vascular co-pathology do? And we'll maybe also throw TDP in the mix. So it's gonna be, like you say, it's gonna be a lot of steps ahead, but and even more challenges. But it's, I think, also exciting that we can already think of these challenges and see them coming and getting prepared. And I think that's really it's very clear in the DLB field that everybody is prepared, everybody's ready. If it's wherever people are, if it's here in Amsterdam or in Newcastle or in Colombia, everyone is getting prepared for what's happening. So that's, I think, very nice to see. And I think I also saw the same poster, by the way. I even took a photo of it. I hope that's allowed, but because I thought it was nice to, that is actually being done and shown what is working, what is not working. Especially because the blood-based biomarkers are getting so much attention, of course, which makes sense. It's going to be great if we can use them in the clinic as well, and for research, but also clinical trials. But that also means we have to know what they do in other clinical diagnoses and clinical phenotypes. I think, Felipe, did you have any other last highlights to add, or?
In the same line of clinical trials, well, there's a lot to work. Results are not so promising as I wanted, but it's a first step. Since the pathology to these trials, these clinical trials that are totally necessary, but let's work on this. Let's wait in which moment we'll have something to help more our patients.
So you're referring to the trial that was presented, I think, today, right? Yeah.
It's a complicated pipeline and a small pipeline compared to AD, as Felipe said. So I think we really need to see what treatments are we choosing and really what treatment can we take from the others. For example, I would love to see a trial of GLP-1 analogs in DLB, because we already have some trials on Parkinson's disease with decent results, but maybe for DLB that will be important with all the part of brain health. That's another topic.
Yeah.
But that also will be great to see what we can learn from other diseases.
Yeah, and probably also when people, let's hope it's going to take a long time, but once people maybe come to autopsy that actually had a treatment, we can also learn more about what that actually did on the, the pathology. Yeah.
Yes.
Yeah. I think to wrap it up, because we've been, I think we can go on for hours, but maybe to wrap it up, maybe give a little bit of message to people listening at home, what you're bringing back from this conference when you're traveling back home this weekend. Maybe we can start
with me.
With you, yeah.
Or in the
no, we'll do the same order again. Yeah.
No, it was an outstanding conference. I learned a lot. I met a lot of people. I saw people that I saw in other conferences.
Yeah.
I think the DLB field is growing in a very interesting way, and it is a field that has something for everyone. If you like motor symptoms, if you like neuropsychiatric symptoms, if you like pathology, if you like treatment, if you like epidemiology, it has it all, and it really needs more people involved with it. So if there is anyone interested in the DLB field, go ahead. And that will be my conclusion.
Yeah.
And Amsterdam is a beautiful city also.
Thank you for mentioning that. Yeah. Good to promote Amsterdam a little bit as well.
Yes.
Thank you for Laura. What are you taking home?
For me, it's kind of the increase of interdisciplinary research. There's clinicians, there's people that work in neuropathology like myself. We're starting to get more fundamental science at this conference, which I really like. So getting a lot of different aspects fed into DLB that we've not really considered before. So I'm really positive about that. Yes, we didn't get the results from some of the clinical trials, but I think they will come in time. I think one thing that hasn't been mentioned, and I don't know if it was mentioned in the previous podcast, but the formalization of an international consensus to really drive that's being discussed today. So hopefully the start of an international consensus, a more formalized society that will hopefully anyone who's interested in DLB and wants to contribute can also, we need as many different minds as possible to come up with solutions and better diagnostics and better treatments and more understanding of the diseases that we're studying. So I think that was a big positive, that we're becoming a better group and we're becoming more cohesive.
Yeah, and we work for our patients. That's the final goal of all of this.
Yeah, thank you.
Okay.
Felipe?
Well, it was great. It was very nice. There is passion. There is passion for learn, work for our patients. And my main message is the importance of teamwork. There is a lot of people that is working for the same goal, each of one from its area of expertise, but there is a teamwork that we have to keep doing.
Yeah, thank you. Well, those were all beautiful messages and words to, I think, end this podcast as we're running out of time. I want to thank, of course, our brilliant guests for today. Thank you so much for taking the time after probably already quite exhausting days and a lot of information that you still probably want to grasp whilst traveling home. So thank you so much. If you want to know more about Lewy body dementia or about the conference, you can still visit the website ilbdc2025.com. I'm Sterre de Boer. Thank you so much for listening to the Dementia Researcher podcast, and we hope to see you next time. Bye.
Bye. Bye.
The Dementia Researcher podcast was brought to you by University College London with generous funding from the UK National Institute for Health Research, Alzheimer's Research UK, Alzheimer's Society, Alzheimer's Association, and Race Against Dementia. Please subscribe, leave us a review, and register on our website for full access to all our great resources. dementiaresearcher.nihr.ac.uk